بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على رسوله الكريم سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. Dear colleagues, this is the second lecture in the series of abdominal imaging, and it will deal with the imaging of the abdominal trauma. And as you all know, this lecture will deal only with blunt abdominal trauma, and the penetrating injuries are not included here, since most of these injuries are usually handled urgent by surgery, and usually there is no time for imaging in most of the cases. But the commonly seen in the clinical practice is the patients with blunt abdominal trauma, where the availability of multi-detector CT has greatly facilitated imaging and the diagnosis of these cases. Then these are the diagnostic options, including the physical examination and some laboratory tests, and many of the patients with no emergency imaging or minor blunt trauma may be put under observation. And this is an old technique which is known as the diagnostic peritoneal lavage, commonly used in the surgical department. And of course, the imaging has a great role in recent evaluation of cases with abdominal trauma, especially the ultrasound and the CT scan. Then finally, in some cases with deteriorating general condition and hemodynamically unstable patients are usually sent for laboratory exploration, laparotomy exploration. Then these are the indications for imaging of patients with blunt abdominal trauma. Number one, the hemodynamically stable patient with abdominal trauma requiring further diagnosis, and post-traumatic cases with localized symptoms or signs and positive laboratory findings, and patients with equivocal clinical examination due to altered mental status. Then, as you all know, we have too many imaging modalities for evaluation of the abdomen, including the ultrasound, the CT scan, the MRI, and of course the conventional X-rays. Then you can use also the radionuclide scans in some cases, and use the facilities of CT and MRI to perform angiographic techniques, and also we can perform interventional maneuvers. Then this is one of the major roles of abdominal ultrasound, is to detect intraperitoneal fluid. And you see this is the liver and this is the kidney, and here is some fluid between the liver and the kidney in the Morrison pouch. And you should know that in any case with blunt abdominal trauma, and you can identify fluid in the peritoneal cavity, and you should suspect hemorrhage, internal hemorrhage. And this is actually the main role of the ultrasound in emergency, is to identify intraperitoneal fluid indicating the presence of hemorrhage. And the patients are usually unprepared for the ultrasound examination, and the bowel gas may disturb the ultrasound images, and so the main target of emergency ultrasound used in the casualty rooms or departments is to detect an intraperitoneal fluid. And of course, you should know that the most dependent part in the abdomen while the patient is lying on his back is the Morrison pouch, while of course the most dependent part in the erect position is in the pelvis. Then whenever you are using CT scan for assessment of blunt abdominal trauma, we usually advise to give the patient oral contrast and intravenous contrast. And oral contrast is usually helpful in detection and confirmation of bowel perforation. And in such cases, you will see that the orally administered contrast medium will leak inside the peritoneal cavity, while intravenous contrast is mandatory, even if the patient, of course, is not fasting. And you should give an intravenous contrast to maximize the difference between the enhancing parenchyma of the liver and spleen, for example, and the kidney, and the non-enhancing hematoma or laceration, as you can see just in a moment. Then intravenous contrast is excreted usually by the kidneys and collects inside the urinary bladder. So if there is urine extravasation secondary to intraperitoneal or extraperitoneal bladder rupture, you can easily identify. Also, the injection of contrast with the use of multi-detector CT scan can detect the site of active bleeding, and you can see the bleeder or the site of bleeding leaking the injected contrast material. And this is a famous protocol for imaging of blunt abdominal trauma. And after initial resuscitation, and you should identify the state of the patient, whether he is hemodynamically stable or unstable. If the patient is hemodynamically stable, then if you are able to do a reliable abdominal examination, then by this examination you can detect evidence for an intra-abdominal injury. If there is no evidence on reliable abdominal examination, then the patient is put under observation. But if there is evidence of abdominal injury on a reliable abdominal examination, then the next step will be to do a diagnostic abdominal CT scan. And if the patient is hemodynamically stable and you cannot do a reliable abdominal examination because of multiple sites of trauma, because of the disturbed conscious level of the patient, because of the airway compromise, and so on, then you should go for the diagnostic abdominal CT. And what to do if the patient is hemodynamically unstable and there is evidence of intra-abdominal injury on clinical examination. Many recommend to go direct for laparotomy and to deal with the injured organ. And in the previous days, if there is no evidence of abdominal injury on clinical examination of a patient who is hemodynamically unstable, they usually go to the peritoneal diagnostic peritoneal lavage. But nowadays, this step has been totally replaced by the imaging by multi-detector CT. Then CT will show positive results and go to laparotomy for dealing with the injured organ if this is necessary. And if the multi-detector CT is negative, then you go, or your attention is directed to treat other injuries. And this is the diagnostic peritoneal lavage. You put some catheters inside the peritoneal cavity and you aspirate blood, which indicates the presence of an internal hemorrhage and one of the organs has been injured. And this is just a comparison between the diagnostic value of CT and the diagnostic value of peritoneal lavage. Of course, the CT is non-invasive. CT can assess intraperitoneal and retroperitoneal injuries. It can show precisely the extent of organ injury and detect the exact site of injury. It also can detect extra-abdominal injuries, like injuries of the pelvic bones, injuries of the lower thoracic cavity and ribs, and so on. And this is the CT scan of patient with internal hemorrhage, and you see the fluid inside the peritoneal cavity. And if you look carefully here, and you can see what's known as hematocrit effect, the sedimentation of blood, which is relatively hyperdense, and the presence of fluid above the hyperdense blood in the dependent portion of the peritoneal cavity. And this is what we call the hematocrit effect. There is massive bleeding in the peritoneal cavity, seen in the CT image of the pelvis, and this arrow points to the sedimentation of the blood, forming what's known as the hematocrit effect. Then the CT visualization of blood in the peritoneal spaces corresponds with amounts more than half a liter, as you know, and the scan should include the pelvis because there may be a collection in the lower down in the pelvic cavity, of course. Then we came to the solid organs in the abdomen, and starting by the most commonly injured organ inside the abdomen, which is the spleen. And the splenic injuries have a good association with the number 3. And these injuries are commonly due to accidents and direct blunt trauma to the left hypochondrium, and sometimes they are associated with injuries of the adjacent organs. Then the grading of splenic injuries include the grade 1, which is a superficial laceration and subcapsular hematoma less than 1 centimeter. Grade 2 is a laceration which is above 1 centimeter and below 3 centimeter, deep laceration with subcapsular hematoma more than 3 centimeter thickness. Laceration, grade 3, laceration more than 3 centimeter deep, and subcapsular hematoma more than 3 centimeter in thickness. Then the grade 4 injury represents fragmentation or shattered the spleen into 3 or more pieces. Then look at the appearance of these injuries on the CT images, and this is the grade 1 splenic contusion. And this is the contusion, and this usually treated conservatively, and after 2 weeks, and you can see some healing at the site of the contusion. Then grade 1 and the grade 2 splenic injuries are expected to heal within 4 months, and the grade 3 will heal in about 6 months, and of course grade 4 is an indication for splenectomy. And this is a grade 2 splenic laceration where the laceration is relatively deep. It's more than 1 centimeter in diameter, in length, and may be associated with subcapsular hematoma. And here you can see the value of injection of contrast media in order to enhance the parenchyma so that you can see the site of the laceration. Then this is grade 3 splenic laceration where you got a deep laceration more than 3 centimeter in diameter and a very big perisplenic hematoma. And as I have said, whenever you see a fluid in the peritoneal cavity after blunt abdominal trauma, you should expect internal bleeding. And in order to know the site of the bleeder, or sometimes you cannot identify injury, specific injury in a solid organ, and you can identify the most likely site of the bleeding by what's known as the sentinel clot sign. And this sign indicates that the fluid adjacent to the site of the bleeding is hyperdense compared to the fluid in the rest of the peritoneal cavity. And if you see fluid around the spleen and the fluid also around the liver, then the bleeding organ is the organ adjacent to the fluid of relatively hyperdensity. And you can see here, this is the relatively hyperdense hematoma around the spleen, and the relatively hypodense hemorrhage in the peritoneal cavity around the liver. And this is grade 4 splenic injury, where the spleen is shattered into pieces, surrounded of course by extensive perisplenic hematoma. And as I have said, the multi-detector CT and dynamic injection of contrast can show the site of bleeding and can show extravasation of contrast from the site of bleeding in the injured organ. And this is a splenic injury with extensive perisplenic hematoma, and you can see the bleeder or the extravasation of a contrast from the site of bleeding. And this is also a case of splenic rupture with extensive intraperitoneal hemorrhage. Here, and you see the laceration of the posterior wall of the spleen, and you see extensive collection, hypodense collection within the peritoneal cavity as well as in the pelvis. And the sentinel clot sign can be easily appreciated here, where you identify the relatively hyperdense collection or hematoma adjacent to the site of injury, and the relatively hypodense bleeding in the rest of the peritoneal cavity. And this is also an example of splenic laceration with sentinel clot sign, where you can see the hyperdense fluid which is adjacent to the bleeder, and the hypodense or relatively hypodense fluid which is adjacent to the liver. This is splenic laceration with hemoperitoneum. And of course, the subcapsular hematoma can occur in the liver, in the spleen, and in the kidney without a clear evidence of laceration. And here you can see the spleen, the splenic parenchyma is almost intact, and there is a big hematoma which is taking the confinement or the contour of the spleen, as you can see here. Then this is the subcapsular hematoma. This is the spleen, and you see an extensive subcapsular hematoma, and also blood within the peritoneal cavity, and the sentinel clot sign is very evident here. And you see the relatively hyperdense collection adjacent to the spleen. The hypodense collection is adjacent to the liver. Then hepatic injuries are almost graded like those of the spleen, and here you can appreciate the value of contrast injection. And this is the pre-contrast scan, so showing hemorrhage inside the liver parenchyma, and after injection of contrast in the same day, in the same time, you got hypodense appearance of the hematoma, because at that time you are comparing the density of hemorrhage by the density of the enhancing liver, which will show the hemorrhage as a hypodense area. But in the pre-contrast scan, the hemorrhage is relatively more denser than the non-enhanced liver parenchyma. And here is a fatty liver. You remember this is the liver which is relatively hypodense compared to the spleen after contrast enhancement, and there is a big laceration in the lateral segment of the left hepatic lobe, and you can see the hemorrhage inside the peritoneal cavity around the site of the laceration. And this is the female child with hepatic laceration and intraperitoneal hemorrhage. And you see here, this is the site of the laceration, and the laceration is relatively branching throughout the liver parenchyma, and you can easily appreciate this fluid in the lesser sac between the stomach and the pancreas. Then this is also a good example of hepatic lacerations, and you see extensive branching lacerations in the right lobe of the liver with no evidence of subcapsular hematoma. And also this is an example of grade 3 hepatic laceration, which is laceration more than 3 cm deep and may be associated with subcapsular hematoma of thickness more than 3 cm. But here you cannot see a subcapsular hematoma, you see only the laceration in the hepatic lobe. And this is an example of subcapsular hematoma around the right hepatic lobe, and you see the hyperdensity of the blood conforming with the hepatic contour. And this is the expected healing of the hepatic injuries, and a mild injury which is compromising less than 25% of one lobe is expected to heal within 3 months, while moderate injury, which represents about 25 to 50% of one lobe, may heal in about 6 months, with an incidence of about 80% of the cases. And severe injury, which is more than 50% of one lobe, only 20% of these patients will heal, of these lesions will heal in about 9 to 15 months. And you see this is a severe hepatic injury with a very deep laceration, and you can easily appreciate the hemorrhage and the intraperitoneal perihepatic collection, and you can see the hyperdense blood here and there, and also you can see blood around the stomach in this in the left hypochondrium. Then we came to the injuries of the kidney, and the injuries of the kidneys are easily diagnosed by CT scan, especially after injection of contrast media. And the CT can show the extent of parenchymal renal injury, and can see if there is urine extravasation or perinephric hematoma, the state of vascular pedicle, if it is avulsed or not, and can also evaluate associated injuries of the adjacent organs like the liver and the spleen. And this is an example of subcapsular hematoma in the kidney, and these are the possible renal injuries after a blunt abdominal trauma: subcapsular hematoma, perinephric hematoma, renal contusion, renal laceration, shattered kidney, and avulsion of the renal pedicle. And here are the classification of, or the grading of renal injuries, and the grade 1 may represent just a simple contusion of the renal parenchyma with some perinephric hematoma, and the grade 2 showing a laceration which is not reaching the pelvic ileal system with a larger perinephric hematoma, and the grade 3 will show a deep laceration reaching the pelvic ileal system with a more sizable hemorrhage, and the grade 4 means that there are multiple renal lacerations or the shattered kidney, and the grade 5 will represent avulsion of the renal vascular pedicle. And this is a huge subcapsular hematoma seen around along the left, the posterolateral aspect of the left kidney, and you can easily appreciate the hyperdensity of the blood here. And the subcapsular hematoma may result from CT-guided biopsies of the renal parenchyma or cases of lithotripsy, and the hematoma is of course present below the renal capsule, not outside the renal capsule, and is separated from the Girotta fascia by the perinephric fat. And this is the Girotta fascia, this faint line, and this is the fat, and this is the subcapsular hematoma. And the grade 1 injury represents just the parenchymal renal contusion, which will not show contrast enhancement. If this scan is obtained without contrast, you cannot appreciate the presence of this renal contusion. Then the grade 2 is laceration less than 1 centimeter and is not reaching the pelvic ileal system, and is associated with some perinephric hematoma, as you can see. And the grade 3 is a laceration extending into the collecting system, and the perinephric hematoma, which is sizable, as you can see here. And this also grade 3, where you can see large hematoma without laceration, and this is the perinephric hematoma enclosed by or bordered by the Girotta fascia, and the hematoma is thick, as you can see. Then this is a grade 3 injury of the kidney with deep laceration reaching the collecting system and a sizable perinephric hematoma, and you can also appreciate the site of the bleeding. Grade 4 means laceration of the kidney or shattered the kidney, multiple parenchymal lacerations with a sizable perinephric hematoma, and these cases are usually treated surgically. Then avulsion of the renal vascular pedicle is an easy diagnosis by CT scan whenever you see that the kidney with avulsion of the vascular pedicle is not excreting the injected contrast material. And here you can see this kidney is good and the vascular pedicle is intact, showing good contrast excretion, and this kidney is not excreting the injected contrast. And in cases of abdominal trauma, you should suspect the avulsion of the vascular pedicle. And this is also an example. You see the intact left kidney, and you see the right kidney, which is not excreting contrast media. And this is the right renal artery, which is avulsed here, and this was confirmed by this CT angiogram showing avulsion of the renal vascular pedicle on the right side. And this is the child who was subjected to trauma to the left side of the abdomen, followed by immediate hematuria. And the emergency CT scan performed without contrast media injection showed a swelling of the left kidney compared to that of the right kidney. And after injection of contrast, and you can see that there are fragments of the renal parenchyma which shows some contrast enhancement and a very big hematoma surrounding the kidney. Then using the reconstructive capabilities of the CT, multi-detector CT, you can appreciate the very deep laceration in the lower pole of the kidney and the excessive hematoma surrounding the kidney. Of course, you can obtain these images in color as you know. Then we came to the pancreatic injury, which of course the pancreas is not commonly injured, being a retroperitoneal structure protected from anterior and posterior, but when in cases of abdominal trauma you may get pancreatic fractures, and these fractures represent linear hypodensities within the enhanced pancreatic parenchyma, and is usually surrounded by low density fluid which represents a retroperitoneal hemorrhage. And this is an example of pancreatic fracture involving in the tail of the pancreas with collection in the Morrison pouch and the space anterior to the left kidney, and this is, of course, represents retroperitoneal hemorrhage, and this is the pancreatic fracture. Also here is pancreatic trauma showing some lacerations in the region of the pancreas, and the follow-up scan after 5 days showed the more bleeding in the retroperitoneal space surrounding the kidney and is located around the site of injury in the pancreatic tail. And this is also an example of a patient with penetrating abdominal trauma after multiple stab wounds in the abdomen, showing a laceration of the pancreatic tail and the presence of hypodense collection in the lesser sac, as well as around the pancreatic tail, as well as around the kidney, representing retroperitoneal hemorrhage. And this is also an example of blunt abdominal trauma sustained in a motor vehicle collision, and you see multiple pancreatic fractures, and this is one, and this is the second one, which is clearly seen here, and there is little fluid around or hemorrhage around the site of the injury, as well as in the most dependent part in the abdomen while the patient is lying supine, which is the Morrison pouch between the liver and the kidney. Then whenever the patient had a history of blunt abdominal trauma and you got pneumoperitoneum, you should suspect perforated discs. And here you can see the pneumoperitoneum is clearly and accurately evaluated by the erect chest X-ray. And you can see here, this is the right diaphragm, and this is air under the diaphragm, between the liver and the diaphragm. And you can appreciate the pneumoperitoneum in the CT scan as well. And finally, the bowel injury, you can see free intraperitoneal air if the bowel is injured or perforated, extravasation of contrast media, intraperitoneal fluid of unknown cause, thickened bowel loop more than 3 mm in diameter, and the mesenteric wall hematoma. Then here you can see extravasation of contrast in the peritoneal cavity along the liver, and in a patient with perforated viscous. And here is an example of bowel hematoma and the intraperitoneal hemorrhage around the inferior wall of the liver. And this is the case of cecal injury with hematoma around the site of injury in the cecal wall. هذا وبالله التوفيق والحمد لله رب العالمين.